Okay, everyone. So sorry about that delay. We just needed to get a couple things up and running so people on Facebook and a couple other sites could see this lecture as well. So I really appreciate your patience. Now, as you can see, we're doing a free webinar on fluid frenzy. We're going to be talking about some electrolyte essentials that you really need to know to pass the NCLEX. And in particular, today we're going to cover potassium and sodium, two of the biggest electrolytes that are likely to show up on the NCLEX. Now, for those of you who don't know who I am, my name is Elizabeth Diger. I've been a tutor with Archer for about a little over 2 years, and I absolutely love it. Prior to that, though, I worked as a women's health nurse practitioner. I spent, about a decade working in OBGYN. And then prior to that, I was a critical care nurse. I worked in ICUs and emergency departments. So certainly had to deal with a lot of electrolytes when I worked in those settings. Now, for those of you currently on Zoom, welcome. Just a reminder, if you have any questions, you want to put those in the Q&A section, the question and answer section, and then the wonderful Jennifer Bonner, one of our great tutors here at Archer, she's going to be able to answer your questions there. But just remember, there's a lot of you and there's just one of her, so it might take a little bit. Now, also for those of you in chat or in the Zoom, we do have the chat open, so you can interact with me there as well. So I might be asking you some random questions today to pick your brain. Put your answers right in the chat, and I'll keep that chat open so I can see what you guys are thinking. Now, we are going to be using Slido today. You can join by scanning the QR code here in the lower left-hand corner, or you can go to slido.com and just type in hashtag AREI or AR electrolytes is what it is. Now that I'm really looking at it. So hashtag AR electrolytes. And I'd love to have you join Slido. But as you can see, I have an important question up. Where are you guys joining from? Oh man, I'm seeing some people join from Florida right off the bat. If you're currently living in the Florida region, I'm thinking of you. I hope you're safe. I hope you get your power and all of those things back very soon, because I know it's very, very hard living in Florida right now after Hurricane Milton. But we have people from not only all over the US, but all over the world, Canada. We have people from Mexico, neat, Nepal, Egypt. This is wonderful. East Africa. Oh no, someone said it's hot with no power. I'm thinking of you. I'm sending as much good energy as I can in your direction. I really feel for you guys. All right. Thanks so much for telling me where you guys are joining from. Now, I have another question for you. How are you currently feeling about fluid and electrolytes? That's the big question. It's a hard area of the NCLEX, but I always tell people this is foundational. If you do not understand fluid and electrolytes, you're going to have a really, really hard time passing your NCLEX. So it's definitely worth spending some time on this. It was wise to join this group. It's confusing. I get it. I saw a meh earlier, doubtful. This is really hard stuff. I should remind you guys, there is a raise hand option. Don't use that if you don't mind. We're not going to have time to actually call on individual people. So again, go ahead and put your answers in the chat or Slido. And then of course, if you have a question, put it in the Q&A. Oh, someone just said it makes me dehydrated. That was very cute. I like that. All right. Well, let's go ahead and dive in. And like I said, today we're going to be covering both sodium and potassium. And those are really two of the most critical electrolytes that you have to know for the NCLEX. So sodium, what do we need to know about sodium? Well, I'm going to underline a couple key points for you. It's the most abundant extracellular cation. So let's break that down. Extracellular means it mostly lives outside of the cell in the serum. There is a little bit in the cell, but mostly it hangs out outside, and it's a cation. It has a positive charge. So remember, positive likes to bind with negative. And that's actually why chloride imbalances typically coincide with sodium. Chloride is the most abundant extracellular anion. It has a negative charge. So sodium likes to bind with chloride. And what does this make? What is NaCl? Tell me in the chat. For those of you in Zoom, what is that molecule? It's something I bet you eat just about every day. Sodium chloride, but that's also known as table salt. Exactly. You guys got it. So by the way, guys, when you're studying chloride, study chloride and sodium together. The symptoms of high sodium are the same as high chloride. The symptoms of low sodium are the same as low chloride. So study those together. Now, one of the other big things you have to know about sodium is water follows sodium. So sodium's going to regulate the water in the body, and water really crashes sodium's party. Wherever sodium's hanging out, water's like, hey, me too, and it likes to go where sodium is. Now, sodium is especially important in the brain. So when you think sodium, if it's high or low, think, how is this affecting my patient's neuro status? How is this affecting their brain? But of course, it also impacts nerves and muscle cells, which is very important as well. And of course, you want to know the normal range, which is 135 to 145. Now, before we get into the causes of hyponatremia, I want you guys to brainstorm. What are some causes of hyponatremia? Let's just spend about a minute on this. Vomiting, yeah, dehydration, diuretics, that's a good one. Too much fluids. Very good. You can actually overdose on water and it affects your sodium level. Addison's, burns, very good. Excessive sweating, diet, diarrhea. You guys are getting it. We'll be talking about pretty much all of these things that you guys are listing. You're doing very, very well. Good. So yeah, let's dive into hyponatremia. Now, the tricky thing about sodium is the causes depend on the fluid status in the body. So there are three different types of fluid status. There's euvolemia, there's hypervolemia, and there's hypovolemia. Those are the three types of fluid status in the body. It's either normal, high, or low. And you can see a lack of sodium with all three types of fluid status. So let's break these down. So first of all, we have euvolemic hyponatremia. That's basically when the water in the body goes up, but it's still in a normal range. There's more water in the body, but technically the client is still euvolemic. They're still in a normal volume status. However, when that fluid volume goes up, it's going to dilute the sodium that's left behind. So when we look at the sodium in this glass here, if we were to take a little sip out of it, it wouldn't taste quite as salty as this glass over here. The water, the increased water, is diluting the sodium. It's decreasing the total sodium in the body. So there are a lot of causes for this. SIADH, remember that causes excessive antidiuretic hormone. You hold on to too much water and it dilutes the sodium. That's a really common cause. We also see this with adrenal insufficiency and Addison's disease. Why is that? Well, with those conditions, you lack the steroid aldosterone. And remember, if you don't have aldosterone, you're not retaining sodium. You're going to be losing sodium in the body. Also, polydipsia, just like you guys said, if you drink too much water, you could have dilutional sodium issues. Excessive hypotonic IV fluids. If you're giving too much water via IV with not enough particles, you're going to dilute the sodium. And then just like you guys said, if you don't take in enough sodium in your diet, you're going to have low sodium as well. Now, we also have hypervolemic hyponatremia. This is when the water in the body goes way up. It really increases excessively to the point of hypervolemia. And of course, this is going to dilute the amount of sodium in the body, and it's going to cause dilutional hyponatremia. So this is normal. There's normal fluid, there's normal sodium. And over here, you can see we have so much fluid overload that it's significantly decreasing the sodium in the body. And we especially see this with organ failure, heart failure, kidney failure, liver failure. Those are all going to cause fluid overload. We also see this with nephrotic syndrome. Remember, that causes that anasarca, that generalized swelling. And then water intoxication. Again, you can do too much of a good thing. You can overdo it with water, and that can cause this issue. But remember, we also have hypovolemic hyponatremia. This is when water and sodium are both lost together, but in this case, more sodium is lost than water. And there's a lot of causes, just like you guys said: vomiting, diarrhea, NG tube suction is a big one. Make sure if your client has an NG, they're not drinking, because that's going to leach all the sodium out of their body. Diuretics, burns, and of course, excessive sweating can cause this as well. Now, real quick, just so you guys know, all of these causes can also cause hypovolemic hyponatremia. It just depends on what that client's fluid and sodium status was before these events happen. So you'll see that in a little bit. But what is the client going to look like if they don't have enough sodium in their body, if they have hyponatremia? Well, remember, the first thing I want you to think about when there's a sodium imbalance is the client's brain. It's going to affect their neurostatus first and foremost. So what are they going to present like? Well, at first, they might be a little confused and tired. Then you can't arouse them. They're stuporous. They could develop cerebral edema. And actually, this could cause increased intracranial pressure, which could actually lead to damage. But the number one thing we worry about with low sodium: seizures. Remember, seizures could be deadly. We want to prevent this from happening. Now, tell me in the chat, how low does the sodium have to go for seizures to occur in general? What is that value? Remember, normal sodium is 135 to 145. Maria, good job. Yes, I'm so impressed by you guys. Less than 125. That's the danger zone. You really got to make sure sodium doesn't go to that point or any lower. Otherwise, they could have seizures. Also, remember, sodium impacts the nerves and muscles. So we're going to see some musculoskeletal issues. And in general, it's going to slow the body down if you don't have enough sodium. There's going to be weakness. There's going to be shallow respirations because the diaphragm is a muscle and that's not working well. There's going to be decreased deep tendon reflexes, spasms, and even orthostatic hypotension. But interestingly, in the gut, it speeds things up. It's going to cause hyperactive bowel sounds, which can lead to some abdominal cramping. Now, when we look at the cardiovascular exam, it really, the cause is going to determine what this exam is going to look like. So if the cause is hypervolemia, if someone has fluid overload, we're going to see signs of hypervolemia, of course. We're going to see bounding pulses. We're going to see hypertension. And that's really a clue that we need to look for those causes. We need to ask ourselves, hey, does our client have organ failure? Is our client intoxicated on water? Or are they drinking too much? It tells us what we need to investigate. Now, hypovolemia is going to present very differently. If the client was excessively vomiting or having severe diarrhea, or they were NPO for too long, they're going to present like they're hypovolemic. They're going to have weak pulses, tachycardia, and hypotension, and they're going to be dizzy. Now, if you have trouble remembering these at all, just remember the mnemonic low sodium. L, level of consciousness, down. O, orthostatic hypotension. W, weak muscles. S, seizures. That's what we really have to watch for. O, osmolality is low in the serum. Remember, sodium is low in the serum. D, diarrhea, increased intracranial pressure. Urine osmolality is high. And then we have those increased bowel sounds. Let's pause here for a second. So for those of you who are not currently a member of Archer, you're just checking in for the free webinar, which is great. We're glad to have you. We just want you to know about some of the things we offer, because we always get a lot of questions about this. It's not to pressure you into it, it's just so you know about it if you're interested. The number one package we recommend is actually our Sure Pass combo. It gives you a lot of value. So not only are you going to get some great on-demand videos, there are dozens and dozens of those. You're also going to get the Q Bank, which has thousands of questions that are similar to the questions in the NCLEX. And then you're going to get a one-time pass to the 3-day live review, which is a really rapid review over 3 days, which ideally is really good to take soon before you're about to test. But that's not all. It also includes all of the live lectures and the live case studies, which are pretty much happening every single day during the week. And believe it or not, guys, this is really good timing. Next Tuesday and Thursday, guess what the live lectures are? Fluids and electrolytes. So if you really struggle with this material, consider joining SurePass. That's going to give you access to those live lectures, and you can learn about this in more detail. And of course, feel free to scan these QR codes. All right. So next we got to get into the treatment. How are we going to treat someone with low sodium? Well, if it's hypervolemic hyponatremia, we're going to have to restore sodium and volume together. They're low in both water and sodium. So if it's mild, we're just going to use a 0.9% normal saline. That's just a nice little isotonic solution. But if it's really severe, we're going to replace it more aggressively with a 3% normal saline, and that's a lot more hypertonic, remember. Now, if you're going to replace it aggressively with this 3% solution, you have to do it slowly, and we'll talk about why in just a little bit. Now, if you have hypervolemic or euvolemic hyponatremia, this is where you've really got to restrict the free water because you have too much water on board. So you're going to restrict how much the client drinks. You're going to replace the sodium with diet. And of course, you can give sodium tablets as well. And then you're going to use osmotic diuretics. Those are going to push water out of the body, but they're going to retain that sodium that the client is low in. So nursing interventions, we would probably want to encourage a high sodium diet, which is rare, right? We almost never do that. But if someone's low in sodium, we want them to eat basically processed foods. We want them to have hot dogs, lunch meat, cheese is very processed, butter, bacon, canned foods. And of course, you can always sprinkle a little of that NaCl on top, that table salt. Sometimes, again, those sodium tablets are going to be prescribed. But remember, if someone has low sodium, check their neuro status because that can be pretty wonky if it's either low or high. But like I said, when you're replacing sodium, you've got to do it really, really slowly. Otherwise, you can actually cause damage to your client. You only want to replace about 0.5 milliequivalents per hour because if you change that sodium level too quickly, causes fluid shifts, and that fluid will actually shift into the brain. You'll get cerebral edema, increased intracranial pressure, and of course, that could permanently damage your client's brain. So be careful, go slow. Now, on the other hand, you could also have hypernatremia, high sodium over 145. Now, I bet you know what I'm going to ask next. What do you guys think can cause hypernatremia? Go ahead and join at slido.com, or of course, you can just answer in the chat as well. Ooh, Cushing's is a good one. Diarrhea. Yep. Diarrhea can cause hypo or hyperglycemia, depending on their fluid status before they started having the diarrhea. Lost fluid. Yep. Then the sodium becomes more concentrated. Too much fluid loss. Yeah. Good job. Fluid volume excess. That would probably more so cause hyponatremia, but in some cases we can see hypernatremia as well. Okay, let's look at the causes. And of course, the fluid status is going to determine the underlying cause again. So first of all, we have euvolemic hypernatremia. This is again where the fluid volume technically is normal, but it decreases enough that it's causing the sodium that's left behind to become more concentrated. So this can happen with that insensible water loss that we can't really detect. You know, hyperventilation, you're blowing off a lot of liquid actually. Excessive sweating and fever can cause this as well. And just like one of you guys said, diabetes insipidus can also cause this. Remember, that causes the client to be dry inside. If you think back to endocrine, there's not enough antidiuretic hormone. Client's going to pee and pee and pee. That's going to lower the fluid volume status, and that sodium becomes more concentrated. Now, we can also have hypervolemic hypernatremia. This is when sodium and water both go up, but you actually have more sodium. And we especially see this when we are doing it to our client, believe it or not. We are usually the cause of this. If we were giving a hypertonic IV fluid for too long, like a 3% saline, we could cause this. If we're giving too much sodium bicarb, maybe to a client who's really acidotic, we give too much sodium bicarb, all of a sudden they're in that hypernatremic state. People can, of course, take in too much sodium, but especially if there's excess steroids, if there's excess aldosterone, that's going to cause the client to retain sodium. So just like you guys said, if we give too many steroids, if the client produces too many steroids because of Cushing's, or if they just have hyperaldosteronism, sodium's going to be really, really high. And then, of course, we can have hypovolemic hypernatremia. This is when the water goes way down, but and the sodium goes down as well. But in this case, there's more water loss, and that's going to concentrate the sodium that's left behind. So you're going to recognize a lot of these causes: dehydration, NPO, diarrhea, vomiting, burns, and diuretics. Those can also cause hypovolemic hyponatremia. They can also cause hypovolemic hypernatremia. Just depends on what that client's fluid volume status was before they started having those things, before they started having diarrhea, before they started vomiting. Now, what is the client going to look like if they have really high sodium? Well, high sodium is also bad. And remember, it doesn't matter if sodium is high or low. You always have to think about that neurostatus first. It's really going to impact the brain. So your client, they might start out being restless and kind of irritable. Then all of a sudden they're lethargic and drowsy. And then what do you know? All of a sudden they're stuporous. They're in a coma. You can't wake them up. It increases in severity as that sodium rises. Now, in the musculoskeletal system, it's mostly going to speed things up. There are going to be twitching and cramps. That's going to cause the muscles to feel weak. Now, when we look at other, this is my trick for other. When you think of high sodium, Think of someone who's trapped in a desert. They're going to present the exact same way. If you're trapped in a desert, you're going to have flush skin. You're going to have decreased urine output, and your mouth is going to be parched. It's going to be dry. You're also probably going to have a low-grade fever. So definitely remember that trick. And remember, the cardiovascular status is dependent on the type of hypernatremia. So if it's a hypervolemic cause, they're going to have edema, hypertension, and bounding pulses. If it was a hypovolemic cause, we're going to see hypotension. We're going to see weak pulses. And of course, we have another mnemonic for you. Don't worry, fried and salted. So F, fever, restless and agitation, increased fluid retention, edema and peripheral pitting if it's hypervolemic, dry mouth, skin flushed, altered level of consciousness and confusion, low urine output, thirst, elevated blood pressure, again, if it's hypervolemic, and decreased energy. So definitely jot down that little mnemonic. It's helpful. Now, how are we going to treat this client? Well, it depends on the underlying cause again. If it's a euvolemic hypernatremia, we've got to replace that water, right? They're technically euvolemic, but they're lacking a little bit of water. So we need to replace that. And we're actually going to do that orally. We're just going to let the client drink as much water as they want. And that's going to help to, dilute that sodium that's in the bloodstream. Now, ideally, we actually don't want to use IV replacement of fluids because remember, the client is euvolemic. We don't want to overcorrect that by accident. We're just going to let them drink what they want. Now, if it's hypervolemic hypernatremia, well, we got to figure out what we're doing to cause it. That's usually the answer, actually. If we're giving too many hypertonic solutions, turn them off. If we're giving too much aldosterone, too many steroids, or maybe if we're giving too much sodium bicarb, knock that off. It's causing the hypernatremia. And additionally, we can give loop diuretics. Remember, loop diuretics are not only going to push that water out, they're going to push the sodium out as well. And then we can give free water administration after they take those loop diuretics. That's going to help dilute any sodium that's left behind. And then finally, for hypovolemic hypernatremia, we really need to dilute that sodium a little bit more aggressively. So that's when we're going to use just a normal saline compared to the sodium in the blood. That's pretty hypotonic. And over time, that's going to correct the hypernatremia. And it's also going to replace that fluid that the body needs. But remember, while you're doing this, monitor that fluid status. And of course, do these corrections slowly. You don't want to really rapidly correct sodium imbalances because, again, that could cause cerebral edema. It could actually harm your client. Okay, let's try a couple Slidos. These are tricky, just to warn you. Okay, first one says, the nurse is assigned to care for a client with a sodium level of 122. Which assessment finding does the nurse anticipate based on this lab result? Select all that apply. What do you guys think? Tell me in the chat or Slido. We'll take about 20-30 seconds on it. Good. Just a reminder, we do not provide any of the slides from the free webinars, but remember, you can always go back and watch this on Facebook. You can find it there. And remember, you can take notes as you go too. I recommend that. Okay, let's see what you guys said. This is a hard one. You did good. Yeah, we would definitely expect confusion. If sodium is low, it's going to affect that brain. It's going to cause nausea and vomiting because it's actually going to speed up the bowels when sodium is low. And then it's going to cause nausea and vomiting for the same reason. But we wouldn't expect hypoactive bowel sounds, and we wouldn't expect tall peak T waves. We'll see that when we get to potassium in a little bit. Yeah, exactly, Hannah. All right. Let's try another one. The nurse is caring for a client whose most recent sodium level was 152. Which of the following signs and symptoms does she suspect are caused by the client's sodium level? Select all that apply again. So let's take another 30 seconds. Okay, I'm seeing some good answers in the chat. Just a reminder, if you have any questions, put those in the Q&A so Jennifer can help you. Okay, let's see. Good job. Exactly. We're going to see lethargy. Definitely, again, whether sodium is high or low, it's going to affect the mental status. It's going to impair it. And then we're going to see those dry mucous membranes. Remember, when sodium is high, think about someone trapped in a desert. We're not going to see fast respirations. We're not going to see hypoventilation either. And it really shouldn't affect the circulatory system. We're not going to see any cyanosis. Okay, real quick, I also want to mention that another good resource we have here at Archer are our small group tutoring options. And these are one of our best deals here at Archer. Basically, you can have up to 15 students in the class. So it's a small class per one tutor, and it's only $25 for the session for a full hour. So really, really good deal. And we teach a variety of things. For example, Kate teaches cardiac EKGs. Lauren, she's our pharmacology master. Rachel does a lot of 2-hour NCLEX review. She does a lot of mock NCLEXs, and so on and so forth. So definitely check this out. Each of our tutors, including myself, including Jennifer, we offer different small groups, which are definitely tailored to your needs. So if you're interested, you're going to be able to practice hard concepts. You're going to be able to do a lot of questions together. It's going to help you learn hard concepts quickly. But we got to dive into potassium next. This is just about as common as sodium on the NCLEX. It's a very common electrolyte that we see. Now, unlike sodium, this is found mostly inside of the cells. It's the most abundant intracellular cation. So again, this has a positive charge. So when we're looking for the normal value of the serum level, that's just the potassium in the blood outside of the cells. That actually doesn't account for most of the sodium or the potassium in the body. Remember, most of the potassium is hanging out inside of the cells. Now, potassium is really important. We need it for nerve impulse conduction, especially in muscles. And what's that most important muscle in the body? The heart. So remember, with sodium, when sodium is high or low, you think brain. When potassium is high or low, you think heart. It's going to impact the heart the most, but it can also impact the skeletal muscles as well. And something else you need to know about potassium is it's really important in the acid-base balance. If someone's acidotic, it actually causes the cells to become leaky. And guess what's going to leak out? Potassium. It's going to leak out into that serum. Serum level of potassium is going to go up. So when someone's acidotic, we should check their potassium levels for sure. Now, the normal potassium is 3.5 to 5. First of all, let's talk about when potassium is low, hypokalemia, less than 3.5. Let's do another Slido. What do you guys think? What can cause potassium to be low? Tell me what you remember from nursing school. Diarrhea is a big one. Yeah, diuretics, not taking in enough potassium. I agree. Vomiting. Laxatives, good one. A lot of people forget that. Too much insulin. Very smart, Polly. That's a very high level concept. Alcoholism is a good one. Yes. Starvation. Yeah. Eating disorders like anorexia. We'll talk about that real soon. Good thinking. Fluid shifting. Oh, you guys have been studying this. I can tell. So, as you can see, there's a lot of causes, and these are going to spell out the word ditch. These are going to cause your body to ditch potassium. It's going to leave the body. So, first of all, drugs, laxatives, especially Kxalate. That's the big laxative that really rapidly pushes potassium out of the body. Diuretics. Tell me in the chat, what kind of diuretics? What kind of diuretics cause potassium to go down? There are two big ones you need to know. Big one is the loop and thiazide. Exactly. So if you have someone on diuretics, loop or thiazide, watch their potassium levels. And then corticosteroids. And let's think about why. Aldosterone is a corticosteroid. That's going to cause the body to retain sodium and water, and it's going to push potassium out of the body. All right. Inadequate potassium intake. So, of course, if your client's NPO, if they have a poor diet, or if they're really restricting their intake, anorexia, bulimia, and actually alcoholism falls under this as well. People who are alcoholics typically preferentially drink alcohol. They're not eating good foods because they're focused on drinking the alcohol. But also, alcoholics have GI tract inflammation. And if your GI tract is inflamed, guess what? You can't absorb electrolytes well. So not only is potassium going to be low, probably you're going to have some other imbalances as well. Too much water. You can get too much of a good thing. Polydipsia. If we give too many IV fluids, those are some big causes. Cushing syndrome. Same idea here with the corticosteroids. If you have too many steroids that the body's producing, you have too much aldosterone. That's going to retain sodium and water. It's going to push potassium out of the body. And then finally, heavy fluid loss. NG tube suction is a big one. If you have someone on an NG tube, check their electrolytes frequently. That's a big safety measure. Vomiting, diarrhea, even wound drainage and sweating can cause this as well. And some other causes would be alkalosis and then hyperinsulinemia. Can anyone tell me in the chat? This is an important concept. Why would insulin cause potassium to go down? Does anyone know? This is quite complex. Someone kind of mentioned it earlier, and I was very impressed. Rhea, yes, you said it exactly. It's going to push potassium back into the cells. Remember, insulin is the key that opens up the cell. And then potassium, it hitches a ride onto sugar, and it gets driven back into the cells, and that's going to lower the serum potassium. Very good job. That's very impressive, you guys. So what are these clients going to look like? Well, they're going to have a decreased assessment. Things are going to slow down if they have not enough potassium. Decreased deep tendon reflexes, weak and flaccid, shallow respirations, decreased bowel sounds, abdominal distension, hypotension, weak pulses. But remember, we've got to think of the heart first. It's going to cause some dysrhythmias. Now, you can remember this with the 6 L's of hypokalemia: lethargy, low, shallow respirations, limp muscles, lethal dysrhythmias, leg cramps, and lots of urine output. Now, you especially want to focus on the EKG. Whenever someone has low or high potassium, that's what you want to track first, actually. And there are some key changes. There's going to be prominent U waves. See that right here. And there's going to be that flat or shallow inverted T wave, like we see right here. That's what we see with low potassium. Now, believe it or not, ST depression right here, and that prolonged PR interval right here, you actually see that with high and low potassium. So those are consistent findings with potassium imbalances. But again, if potassium is low, we're specifically going to see the U wave, and we're going to see that flat, shallow T wave. That's what you really want to focus on. So how are we going to treat these clients? Well, like I said, first thing you have to consider is the heart. You've got to put them on telemetry to make sure they're safe. But of course, you're going to hold any potassium wasting drugs. You're going to give them a diet rich in potassium. You're going to give them oral potassium supplements. Make sure you give those with food because they're really hard on the tummy. And then you're going to give IV potassium. And we see this here, POD, potassium IV, oral potassium, diet rich in potassium. Now, tell me, guys, why on earth would we hold digoxin? That's not going to impact the potassium level. Why would we hold that medication? What do you guys think? Tell me in the chat. Very hard concept again. Yes, Hannah. Madonna, you guys are good. Exactly. Potassium, when it's low, can enhance digoxin toxicity. It increases the risk of digoxin toxicity. So if you have low potassium and you're prescribed digoxin, don't take your digoxin. You're going to become toxic. Now, real quick, there are a couple big rules about IV potassium administration. The big thing you need to know is IV potassium is actually a very high risk, dangerous drug. Believe it or not, only the RN should be giving potassium, and usually it requires 2 nurses together to do a med check. Now, ideally, we want to give this in a central line, like a PIC or a Hickman, because when you give this peripherally, it can be a vesicant. If it gets out of the vessel, it can cause that extravasation, and it can lead to damage like you see right here. So central line is better. But the big thing I want you to take away, never ever give potassium as an IV push. We're always going to do this on a secondary line on the IV, because if you push in potassium really fast, guess what can happen? It can actually cause your client's heart to stop suddenly, sudden asystole. So never push potassium. Exactly, death. It can cause death. Now, of course, we can encourage a diet rich in potassium, and there are a lot of foods that have potassium, as you can see. Some of the big ones that show up on the test are going to be oranges, bananas, of course. Most people know that. Potatoes, avocado, kiwi shows up a lot. Spinach is a big one. Fish is a big one. So definitely review this list. There are a lot of foods high in potassium, but especially oranges, bananas, and avocados. Those are the main sources we see show up a lot on the NCLEX. And of course, we can also do potassium supplements. You can give a variety of supplements like K-Lite, Slow K, but do know these taste pretty awful, and they're really hard on the stomach. They cause a lot of indigestion, reflux issues. So just make sure that you always give it with some food. And then, of course, IV potassium. Again, don't give it IV push. Put it on a pump. Okay, before we wrap up with hyperkalemia, high potassium, last thing I want to talk about for what we offer here at Archer is our private tutoring. And this is another one of our really, really good resources. Myself and Jennifer do private tutoring. We're really the ones who specialize in women's health. Jennifer is a midwife, actually. I'm a women's health nurse practitioner. Megan does a lot of pediatrics. Kate, again, does a lot of cardiac. Cardiac. Lauren does a lot of pharmacology, and Carly Allie and Emma, they can do just about anything. They do a variety of different tutoring sessions, and it's completely individual to your needs. It's a one-on-one. Your tutor can give you a customized study plan. They can help you learn difficult content. They can do a lot with you, and it's just $75 an hour. So again, no pressure, but if you're really struggling to prepare for your NCLEX, this can be very, very helpful. And of course, you can just scan this QR code to book it. Okay, so next we're going to talk about hyperkalemia, and this is what we're going to wrap up with. Tell me, guys, what can cause hyperkalemia? What causes potassium to be high? Ooh, that's a good one. Renal failure. I like that one a lot. Ooh, tumor lysis or burn. Very good. Medications. We're going to be talking about those. Yes, those potassium sparing diuretics. Yep, spironolactone. You guys got it. Diabetic ketoacidosis. Ooh, that's a good one. Excellent, guys. Burns. Yeah, I like that emoji there. All right, so let's dive in. Let's talk about what can cause high potassium. Now, there are a lot of causes. Certainly, if too much potassium is moved from inside of the cell to the outside of the cell, potassium is going to be high. So like you guys said, burns, any type of tissue damage, especially crushing injuries, and then diabetic ketoacidosis. Remember, when you're in DKA, your body's really acidic. That makes the cells really leaky, and potassium is going to leak out of the body. Also, you can take in too much potassium by taking it in too much orally, taking too many supplements or dietary forms, or your body can retain too much potassium, like we see with renal failure. And then, like you said, there are a couple medications that cause potassium to go up in the body. Those potassium sparing diuretics and ACE inhibitors are a big one as well. And the causes are spelled out in the mnemonic machine: medication, acidosis, cellular destruction, hypoaldosteronism. Remember, if there's low aldosterone, we're going to retain potassium. Intake, renal failure, and impaired excretion. Now, what is the assessment going to look like? Well, especially it's going to slow down the body actually quite a bit for a lot of different things when we see hyperkalemia. It's going to cause muscle weakness. And remember, what's that important muscle in our body? Our heart, of course. So it's going to impair contractility of the heart. There's going to be weak pulses, bradycardia, and hypotension. And what we're most concerned about is it's going to cause some EKG changes. But it's also going to slow down respirations. It's going to cause numbness because it's going to impair that nerve firing. And it's actually going to speed up the bowels. That's the one place we see things speed up: hyperactive bowels, which cause cramping and diarrhea. Now, the mnemonic for this is murder. If potassium is too high, it can murder your client. It's how I remember this. Kind of distressing reminder, but it's effective. So M, muscle cramps. U, urine abnormalities. Respiratory distress. Decreased cardiac contractility. EKG changes is the big one. And then depressed or absent reflexes. And again, the EKG changes are often what they're going to actually test you on the NCLEX. So the key ones are going to be that tall peak T wave, like we see right here, and then that widened QRS, like we see right here. Remember, whether potassium is high or low, we're going to see that depressed ST segment, and we're going to see that prolonged PR interval with both. And the reason we get so worried about hyperkalemia is this can actually lead to heart block. Then it can progress into ventricular fibrillation, and eventually it can kill your client. It can cause cardiac arrest. So how are we going to treat these poor clients? Well, we're going to do a variety of things. And do note that the interventions depend on how severe the high potassium is and whether or not there are symptoms present. So, of course, one of the first things we're going to do, we're going to monitor that EKG to make sure they don't progress into that fatal arrhythmia. We're going to discontinue potassium supplements, and we're going to restrict potassium in the diet. We're going to give calcium gluconate. Now, let's pause here. Tell me in the chat, guys, if we give calcium gluconate, is that going to lower the potassium? Is that why we give it? No, Madonna, you're right. That's not why we give it. We give it because it's cardioprotective. It's going to protect the myocardium. It's going to stabilize the heart muscle, and it's going to prevent them from going into that cardiac arrhythmia. You guys got it. We're also going to drive potassium into the cells. And remember, insulin is the key that opens up that cell. And we're going to give a little sugar water. That way the potassium hitches a ride onto that sugar, and then the insulin drives it back into the cell. And believe it or not, albuterol and bicarbonate can also push potassium into the cell, but we don't use those as often. We can also remove potassium from the body with laxatives like caxylate, with diuretics like hydrochlorothiazide and furosemide. And believe it or not, if that potassium is sky high and none of the other interventions are working, we can use dialysis. But again, this would only be for a really severe form of hyperkalemia. And again, we have yet another mnemonic for you. We're throwing all the mnemonics at you today. So the treatment is going to be cried. I had so much potassium that I cried. It's kind of how I remember this one. So C, we're going to give that calcium gluconate. That's going to protect the cardiac muscle. We're going to remove sources of potassium. We're going to increase excretion with diuretics and laxatives. We're going to enhance potassium intake into the cells. Usually we're going to do that with insulin and sugar water. And then last ditch effort, if nothing else is working, we can always do dialysis. All right, let's do a couple Slidos to wrap up, everyone. These are tricky again, so just do your best. So our first one says, the nurse is evaluating a client's lab results and notes that the potassium is 5.5. The nurse reviews the telemetry monitor and expects to see which of the following signs. And of course, it's a select all that apply. I couldn't make it too easy for you. And just a reminder, if you have questions, you can throw those right in the Q&A. I know this is confusing stuff. Beautiful job in the chat, guys. Let's see how you guys are doing in Slido. Let's take a peek. Oh, 98, 90%. Okay, you guys just impressed me. That was really good. Exactly. So the first thing you have to do is ask yourself, what does this number mean, right? You have to define the number, and 5.5 is a really high potassium, of course. So that's going to cause those tall peak T waves, and it's going to cause that widened QRS interval. Prominent U waves, that would be low potassium. A PR interval less than 0.2 seconds, it's going to be prolonged. And inverted T waves, nope, that would be for low potassium. All right. So just a reminder, when you think high potassium, think tall peak T waves, wide QRS. When you think low potassium, think prominent U waves, shallow T wave. Those are the main things they're going to test you on. So that's what I really want you to be hyper focused on. Okay, let's do another Slido. This one says, the nurse is reviewing client assignments for the shift and has each of the following clients. Which client is most at risk for hypokalemia, low potassium? So we're just looking for one answer here. This is a hard one. A lot of different answers. Let's take 10 more seconds. Ah, Marissa, good catch. It's really easy to think about this the wrong way. We'll go through it. Don't worry. Okay, let's look. A lot of you guys got this, 56%. Like I said, this was an especially hard question. So if the client has hyperemesis gravidarum, what are they doing? What are they doing? Tell me in the chat. What's happening to these poor women? Blah. Yeah, they're vomiting all the time. And if you're vomiting a lot, you're going to vomit out potassium. You're not going to absorb it into the body. It's going to leave the body through the vomit. With renal failure, well, or let's do diabetic ketoacidosis. Remember, that causes the body to be acidic. That causes the cells to be leaky. Potassium exactly is going to leak out of the cells into the serum. Potassium's going to go up. Renal failure, potassium is going to go up. The kidneys aren't working. They cannot get rid of the potassium. It's going to build up in the body. You're going to have high potassium. And then third degree burns. Those cells are going to get leaky. All of the potassium in the cells is going to leave, and we're going to see potassium go up because it's going to enter the serum, and the serum potassium is going to go up. So, man, that took some high level thinking. That was a very, very hard one. Okay, let's do one final Slido. The nurse cares for a client with a potassium of 5.7. The nurse understands that this potassium level may be caused by what condition? Select all that apply. Let's just take 30 seconds on this because I see we're just a little over, and then we'll be all set. Mm-hmm. Seeing some good answers in the chat for sure. Let's take 10 more seconds. All right, let's see. Ooh, this was a hard one. So definitely this is a high potassium. What's going to cause high potassium? Well, adrenal insufficiency. You're not going to have enough aldosterone. So aldosterone is what pushes potassium out of the body. So if you don't have enough of that, potassium's going up. Salt substitutes. Well, guess what those usually are? KCl, potassium chloride. Those are going to cause potassium to go up. Cushing's disease is going to cause potassium to go down. Hyperinsulinemia, down. Nasogastric tube suctioning, it's going to cause it to go down. Remember, Cushing's has aldosterone. That pushes potassium out of the body. Insulin pushes potassium into the cells. And nasogastric tube suctioning sucks that potassium out of the body. So it's going to cause it to be low. All right. And believe it or not, guys, we made it. We got through sodium, we got through potassium, and I thought you guys did really well. These are very, very complex concepts, but remember, this is foundational to actually passing the NCLEX. You've got to know those fluid and electrolytes well, or it's going to be really, really hard to pass that test. So we have our final slide here. We just want to reinforce that we do care about you here at Archer. If you guys ever feel stuck, if you ever just feel like I don't know what to do, I can't pass my NCLEX, I feel all alone, you're not. We're here to help you. Remember, you can always email us at nclextutors@archerreview.com, and we absolutely can help you. So reach out to us, book a private tutor, book a small group, and I promise we can help push you towards that goal of passing your NCLEX. All right. Thank you so much for joining, everyone. I thought all of you did excellent. I hope you all have a wonderful day. And I do just want to say again, for any of you in the Florida region, for any of you affected by Hurricane Milton, Hurricane Helene, we are thinking about you. We care about you, and we hope you stay safe. We hope your power's back on soon. Take care of yourselves. All right. Have a great day, everyone. Take care.